All right, we're going to go through cardiac defects of babies that are born with these anomalies. Trying to understand the blood flow. It's more for just understanding the physiology behind it and how it affects us as respiratory therapists. I don't go into detail about the different surgeries that are required to fix it. So it's more about just understanding the physiology. When we're going through the defects, we're going to put the defects into a category, and we're going to call them either an acyanotic defect, where the defect does not lead to cyanosis or deoxygenated blood, versus a cyanotic defect, where there's shunting going on, a right to left shunt going on, and deoxygenated blood is getting into the aorta. So those are our two categories. So this one talks about a cyanotic defect without cyanosis. And that happens with a left to right shunt, where blood from the aorta that has picked up oxygen is now being shunted back into pulmonary circulation. And that happens through the ductus arteriosus. The result is increased pulmonary blood flow. This does not interfere with oxygenation. So the first example you've heard of, so a patent ductus arteriosus, especially in the preemies, their ductus stays open. The blood is in the aorta, and then it ends up being shunted back into pulmonary circulation. The other two you'll know about later on in the lecture, and then when you come back and review this, you'll go, oh yeah, VSD makes sense. Oh, AV canal, that makes sense. So I'm putting them on the list without explaining them for the moment. The next category is the cyanotic defect, where blood is in the pulmonary artery. It ends up getting into the aorta. So from the right heart to the aorta. Blood does not get oxygenated. It causes a decrease in pulmonary blood flow. The infant will not oxygenate. And we learned about persistent pulmonary hypertension being a right to left defect, but that's just because of pulmonary hypertension, not because of something going on with the heart. You'll learn about tetralogy of flow, and then you'll understand why that falls into the category of a cyanotic defect. So to review fetal circulation, we have blood coming from the placenta after it gets oxygenated, from the mom's blood. The blood travels back towards the right heart. It bypasses the liver because the mom's blood already detoxified and broke down anything in the blood. So the blood enters the right atrium. From the right atrium, there's two pathways that blood can take. One of the pathways is the blood goes from the right atrium through the foramen ovale. It's a flap that's open during fetal circulation, and the blood enters the left atrium. Once the blood is there, it goes through its normal pathway, just like the adult, where it goes from the left atrium, left ventricle, and then when the heart contracts, it pushes the blood into the aorta. The other pathway is blood enters the right ventricle. And when it does, when the heart contracts, blood in the right ventricle gets pushed into the pulmonary artery. Well, in fetal circulation, the pulmonary vessels are tightly constricted. So only 10% of all blood flow actually flows to the lungs. The rest of it is going to flow through the ductus arteriosus and get into the aorta. So that's fetal circulation. And then once the baby's born and we get high systemic vascular resistance when the umbilical cord is clamped, it causes high pressures on the left side of the heart, and that causes the foraminal valve to shut. The baby takes in a deep breath of air that dilates the pulmonary vessels, and now you have adult circulation occurring at the time of birth. Some of the cardiac anomalies that we're going to talk about, we need to keep the ductus arteriosus open in order to get pulmonary blood flow. So blood isn't able to get from the right ventricle into the pulmonary artery. So we kind of depend on blood getting from the aorta into the pulmonary artery. And again, it's listing the anomalies that we haven't talked about yet. I know on one of the exam questions it asked about persistent pulmonary hypertension, it would be best to put a coil around the ductus arteriosus and stop the blood from flowing into the aorta. That's not a good idea, because if blood can't get into the pulmonary vessels, blood can't get into the ductus arteriosus. Imagine the right heart eventually failing in a very short period of time because there's nowhere for the blood to go. So you're going to get right heart failure from that. Yeah, it wouldn't be a good idea.
I had a baby in the NICU, right? And he got a large PEA, and they're gonna put a coil. They're sending him to Memorial, so they can do surgery to put the coil in.
Okay.
But that's gonna
So
cause his right heart to fail.
no, he probably doesn't have pulmonary hypertension. He probably doesn't have PPHN.
Okay. So that only happens if they have PPE.
Yeah.
Oh,
Yeah, with PPHN, you kind of use the ductus arteriosus to relieve all the pressure since the blood can't flow to the lungs. Another thing you'll be asked to do is keep FiO2s low, even keep FiO2 less than 21%. How the heck are you supposed to get less than 21%? And you'll typically bleed in some nitrogen into the ventilator circuit or into the air that the baby's breathing, and that will bring it down to less than 21%. Why would you want to have really low oxygen? For some babies, there's too much blood flowing into the pulmonary vessels. What did I do? So if you increase pulmonary vascular resistance, you're going to prevent all of that extra blood flowing into the pulmonary vessels. So that would be a reason for using subapnea oxygen therapy. Do you remember the effect of being hypoxic on pulmonary vessels?
Doesn't it constrict the pulmonary?
Yes. So that's the connection here. If you can keep the baby hypoxic, it's going to make the pulmonary vessels constrict. If the pulmonary vessels constrict, you're going to have less blood flowing through the pulmonary vessels. So it kind of prevents all that extra blood from flowing through the pulmonary vessels.
Where does it go?
Ductus arteriosus. So the most common cardiac defect is a patent ductus arteriosus. And the more premature the newborn, the higher the incidence of them having a ductus arteriosus. So the ductus arteriosus, we know, is a blood vessel that connects the aorta and the pulmonary artery. Normally, it closes itself shortly after birth. If the ductus arteriosus remains open, blood is shunted from the left to the right, from the aorta back into the pulmonary artery. And then it explains why that happens. Higher pressure in the aorta pushes the blood into the ductus and into the pulmonary artery. So the result is you get this increase in pulmonary blood flow. So in order to get the ductus arteriosus to close, we need to block the prostaglandins. So there's some different medications that do that. And indomethacin is probably the least used of prostaglandin inhibitors. Let me put some notes here. I realize when I write the notes on the slide, it's probably better. So indomethacin, yes, it'll close the ductus, but there's side effects to it. So it's better to use ibuprofen or Tylenol. Those are prostaglandin inhibitors. And once you remove those circulating prostaglandins in the blood, that's what's keeping the ductus open. So by removing the prostaglandins, you're now allowing the ductus to close. So I don't know if this is like a disclaimer in here. It says in full-term infants with pulmonary hypertension, blood may flow from the pulmonary artery into the aorta via the PDA. So blood flow can be both from the aorta into the pulmonary artery, or if there's pulmonary hypertension, the blood can flow from the pulmonary artery into the aorta. So it's always going to flow from higher pressure to lower pressure. If you have really high pressure in the pulmonary vessels, the blood's going to flow into the aorta. So typically with just a pure PDA and you don't have pulmonary hypertension, you've got left to right. But this is describing right to left, where when you have pulmonary hypertension. Let me put some brackets around it.
You want another question?
Uh-huh.
I thought PDA was like just for like neonates, like not full term. So is it just like in that case, if they're full term and they have a PDA of some sort, is that they always get the coil for that?
So preemies have a PDA, yes. Full term, if they have a PDA, it's probably because the pulmonary hypertension is forcing blood through the ductus.
So it's forcing it to stay open.
And it's forcing it to stay
So
open.
it'll close automatically as soon as they get the hypertension.
Yes. Yeah. So let me just put a bracket around this. So this is referring to right to left shunt. It's not very, it doesn't stand out very well. So I just don't want you to get confused because we're talking about babies being born premature, their ductus is open, you've got blood from the aorta coming into the pulmonary artery. And then this slide starts talking about pulmonary hypertension and blood will flow from the pulmonary vessels into the aorta. So I just wanted to put a bracket around it to make you understand that.
Is this, I guess, a symptom of the treatment? I guess I'm confused by its placement. Like it comes after the treatment. Is this a side effect of the treatment? Or
No.
Like, okay.
Yeah, it's not a good place, is it? So it probably needs its own separate slide because the treatment is for a ductus where you don't have pulmonary hypertension, it's just open.
Okay.
Mhm. All right, so this is showing like normal circulation except for blood in the aorta. You've got your high pressure and it's pushing the blood through the ductus arteriosus and into the pulmonary circulation. So this is the PDA. Can you see that you're having a lot more blood flow coming into the pulmonary circulation? So a lot more blood flow than normal. And that can affect the pulmonary vessels. Like if that's allowed to continue, it causes permanent pulmonary hypertension, where you get like airway remodeling, it's called, and the pressures remain high, even if it's the blood flow is eventually reduced. So it's not good to allow that ductus arteriosus to stay open. Corinja?
So PDA causes PPH.
No, not at all, no. So when we use the term PPHN, we're referring to persistent fetal circulation because of a hypoxic event. And that's causing the pulmonary vessels to constrict. When you're having excess blood flow from a patent pulmonary PDA, the mechanism is different. So all that extra blood flow is causing high pulmonary pressures.
Oh, so they don't have anything to do with each other.
No. Yeah, does everybody understand that? Just so you can get it. So we talked about PPHN, period of hypoxia at the time of birth, constricts the pulmonary vessels. It's hard to get them to open up again. So that's going to cause obviously high pulmonary artery pressures. Now we've got another situation that we're talking about, which is a patent ductus arteriosus and having an excess amount of blood flow going into the pulmonary vessels. That's going to raise pulmonary pressures. But no, they're not related to each other.
That's when you see the premies on the nitric too.
PPH
PPHNs for nitric, but preemies don't technically get PPHN, but I've seen preemies on nitric.
Wow.
And I
Why?
asked, that's what I asked Ralph, I asked Kim about it separate times, and we were both saying, Kim was saying it's approved by FDA for full term with PPHN, but it's also used on preemies to prevent like a hypertension they get from the PDA.
Ah, okay. Interesting. So they still treat it. Oh, that's crazy.
I've seen it more than once.
Yeah.
PDA, the hypoxic event then is when the blood flows from the aorta to the right or into pulmonary circulation. That's less oxygenated blood being dispersed.
Aorta is oxygenated blood
Right.
going back into the pulmonary vessels.
So when you lose oxygenated blood in the aorta, is that what's causing the hypoxia? Because not as much blood is being circulated throughout the body, oxygenated blood. Or what is the hypoxic event associated with?
Only when blood gets into the pulmonary artery, does not travel to the lungs, crosses the ductus into the aorta, deoxygenated.
That's the case in persistent pulmonary hypertension, right?
But she's asking about where the deoxygenated blood comes from, right?
Well, no, because with persistent pulmonary hypertension, it can be caused by any hypoxic event, you said, right? And PDA is something that can lead to it. But what's the hypoxic event with PDA? Or is there even a hypoxic?
There isn't. It's just prematurity has a lot of prostaglandins circulating in the blood and that keeps it open.
So, does it,
Should we put down like let's do the list of things that occur.
I just don't get why. Yeah, because I get that we have increased blood flow in the pulmonary circulation. But. Okay, just do.
No, because I want to list it, so. So we have a PDA. Blood flows from, you want to do aorta first?
Mhm.
All right, so that's PDA, blood flows from the aorta to the pulmonary artery. It's oxygenated blood flowing back into the pulmonary artery. And then say what you were saying earlier.
okay, question, Professor. So when it goes back into the pulmonary artery, that's where it mixes with deoxygenated blood.
No, no, there is no deoxygenated blood when it's just a pure PDA.
I think where I'm getting confused is we said persistent pulmonary hypertension is caused by a hypoxic event, right? But a hypoxic event leads to the pulmonary arteries to become more constricted. And then we get backed up blood flow or increased resistance because of the constricted blood. But I also know that a PDA can lead to persistent pulmonary hypertension. So why, if there's no hypoxic event associated with PDA?
So that was Corinne's question also.
Said that it wasn't the case, so. I don't know.
That's why I'm confused.
Okay. So we found it. We found the confusion. So PDA leads to, let me fix it. A PDA leads to increased blood flow in the pulmonary arteries. Even though there's no hypoxic event.
Okay. So it's kind of. Just increased resistance.
Because of all the extra blood flowing.
But
Mhm.
that doesn't mean that the pulmonary arteries are necessarily dilated or I mean constricted.
Right,
That's
right. Yeah,
So with PDA, are the pulmonary arteries like patent?
yeah. Whoops. Yeah, so with PDA, the pulmonary arteries are patent, they're wide open. The problem is there's just so much blood flowing through them. It's causing increased pulmonary artery pressures. Yeah, sounds better. Okay.
I think a lot of us were thinking that the PHN was strictly because there's a high toxic in it and then constricted. But now that we know the time, it's without constriction. Makes sense.
Oh, okay.
I mean, I was lost since the first part where I kept seeing the preemies with the nitric and I'm like, I thought PPHN is for full terms.
So yeah, to treat that is interesting. I'll talk to Rolf about it. Trying to understand why they would want the pulmonary vessels to dilate and to allow that engorged amount of blood to be coming through there. I know they must have a reason, and I'm sure there's plenty in the literature to document it, but
Like a hemorrhage or something.
okay.
Just to verify.
Gretchen Taylor, are you okay with understanding the difference between PDA and PPHN?
I understand it.
Hey, did you guys go back to sleep? No. That's not right. We're here, we're awake.
I understand it.
Okay, the next congenital cardiac defect is atrial septal defect. It says there's a hole between the atria, meaning that the foraminal valve the flap didn't close. And now there's a communication between the left atrium and the right atrium. There's higher pressure in the left atrium, and that ends up pushing blood back into the right atrium. Do we have a picture? So here it's showing it as a circle, but the foraminal valve is a flap, and when the flap, when the high pressures in the left atrium push on the foraminal valve, the flap just closes this opening, and then eventually it just becomes part of the wall. But if the flap didn't develop correctly, when it closes, there's still blood able to flow, and it flows from the left atrium back to the right atrium. Why do you think it flows in that direction?
Pressure greater.
Very good. The pressure is higher in the left atrium compared to the right atrium.
Because it has systemic vascular resistance, whereas the other one has the pulmonary vascular resistance.
Yes. All right, is this a cyanotic or a acyanotic defect? Very good. So you've got oxygenated blood going back into the right side of the heart. So that's going to be acyanotic. The next defect is a hole between the ventricles. It's called a ventricular septal defect. And then you just usually hear VSD as what it's referred to. 20% of all congenital heart defects. So you come across this often. So you have higher pressure in the left ventricle compared to the right ventricle. So when the heart contracts, the high pressure in the left ventricle is going to push blood over to the right ventricle. It's diagnosed using ultrasound or echocardiography. You're going to hear different heart sounds as the blood goes through the opening into the right ventricle. It can also be picked up during cardiac catheterization. So is this a cyanotic or acyanotic defect? Why is that?
Because oxygen blood is going to the deoxygenated.
Very good. So acyanotic defect. When we have oxygenated blood going back to the right side of the heart, we call that acyanotic. Make sense? Should we make a list?
So at this point, they've already switched over to adult circulation, right?
Mm-hmm.
So when they get less oxygenated blood pumped out to the rest of the body, that doesn't affect their oxygen levels?
It does affect their oxygenation levels,
It's just not enough.
but it's not happening in this situation.
Does it affect their cardiac output?
Yes.
Because the blood from the right ventricle will eventually become just as oxygenated and pumped out. So that's not.
Yeah. When there's oxygenated blood in the left ventricle, that tells you that the blood has already gone to the lungs, it's already picked up oxygen, and now it's in the left side of the heart. When the heart contracts, it's supposed to go into the aorta, right? And carry that oxygenated blood into the aorta. But instead, the oxygenated blood is going back over to the right ventricle. So having that extra oxygenated blood in the right ventricle, you're not going to see cyanosis.
So it's just not going where it's supposed to go, but it's still oxygenated blood. That's why they're not cyanotic.
But a
Yes.
reduced cardiac output will cause like hypoxia.
That's what I'm saying, reduce cardiac output. Stop it.
That'll-
Okay, so yes, you're going to have a reduced cardiac output because blood is going into the right ventricle instead of into the aorta. Yes,
So
Can that cause?
but that
hypoxia?
blood, that cardiac output that does get into the aorta is oxygenated blood.
Yes.
Okay.
But you're saying will it cause hypoxia, though, right?
will the PaO2 just be lower because it's reduced cardiac output?
No,
Okay, that's what I wanted to know too. Thank you,
not at all.
but it still puts strain on the heart.
Yeah. Yeah, you're gonna get increased pulmonary blood flow from it. The right heart has to work harder. Yes. Yeah, you're having extra blood flowing in the right ventricle. So yeah, you're going to get more blood flowing in the pulmonary vessels. Question?
Yeah. Do you know the percentage of like, is that close to the right atrium?
Percentage of blood that way?
Yeah, I'm wondering if it's like such a. You got to remember. Sorry, it's such an significant amount that it like doesn't. Or.
So the opening varies from one patient to the next. A small opening, they don't treat it. They just let the baby's heart grow and then they, it eventually closes itself. It's only if it's big enough and creating problems that they'll actually go in and put a patch. Yeah, so the size of the hole varies.
I guess that was my rationale for why it wouldn't lower the PaO2 or affect the oxygenation of the patient is like, if it was such a small percentage of blood going to the right side of the heart, then it wouldn't really affect the patient. But does that not have anything to do with it? Or-
So even with a large hole, the blood that gets into the aorta has been oxygenated.
Mhm.
So if you put a pulse ox on the baby, it's still gonna show good oxygenation.
Okay.
Yeah, so Tiffany, I don't know why you're thinking with a low cardiac output that the patient's gonna have a low oxygen saturation. Unless you're used to adults that have heart failure that cause pulmonary edema, they have a hard time oxygenating. And that's why low cardiac output causes them to be hypoxic. But-
It's just, it's less blood flowing throughout the body, so what if it doesn't reach everywhere it needs to? I don't understand.
If it doesn't reach all the organs, then you're gonna have a death in a few minutes. If you're not perfusing the kidneys, the brain, the heart, you're gonna be dead in a few minutes.
Yeah, me too.
Less
again.
blood, less oxygen in the blood. That's what I think that's used.
Yeah.
Yeah, that's not true. So,
So
yeah, that doesn't go
with-
together at all.
Even with a lesser amount of blood, we still get adequate perfusion to all the organs.
Yes, but that wasn't your initial thought. Your initial thought was if you have less blood leaving the left ventricle, that means it's less oxygenated. And that's not true.
No, that was not my initial thought.
Good, okay.
That was her initial saying, but her thought was what she
Yeah,
just
yeah,
said.
like, so like.
Ah,
My concern was perfusion. I know the blood is oxygenated and still has the same level of oxygenation. But I was like, less blood reaching organs, then wouldn't that mean less oxygenation to those organs because there's not as much blood?
yes, you will have tissue hypoxia with a decreased cardiac
Yeah.
output.
That's okay.
That's what I was trying to do. It's Monday, guys.
So this is what you were stating. Okay, and then just to know that with VSD, the size of the opening varies. Or maybe I have it coming up. No. All right, so opening of the VSD can vary in size, I guess I'll put. So I wrote the VSD can vary in size. A small opening is allowed to close on its own as the baby grows. So the large VSD is what needs a patch. So a large VSD will require surgery. So it says the lungs can be damaged from the extra blood flowing back to them. Does that make sense? Where's the extra blood coming from? Very good, the right ventricle. So you get extra blood coming in the right ventricle, extra blood is going to go into pulmonary circulation. And then it says if asymptomatic, they wait until the age of 3, because by then the septum may grow together. And here's showing the ventricular septal defect, where blood from the left ventricle is coming back into the right ventricle. And that's going to cause extra amounts of blood to flow into the pulmonary circulation.
That's pulmonary edema also.
Yeah, good point. Yes. All right, so are we good with VSD? All right, I'll go forward. Coarctation of the aorta. The word coarc means to narrow. I don't know where, how or where, but that's what it means. There's a narrowing of the aorta. So the babies are born with a small aorta. The narrowing decreases the blood flow to the body and makes the heart pump harder against the smaller than normal opening. So left ventricle really struggles with babies that are born and their aorta isn't large enough, because the left ventricle typically has a big workload to pump blood to the body. But now put a narrowing and now it's got to pump blood against this small opening. So it takes a much stronger contraction of the heart to try to push the blood past that narrowing. So then it tells us such high pressures will cause the blood to back up. Does it show us a picture? So for coarctation of the aorta, it's just showing this part smaller. So when the left ventricle pumps, it's got to push the blood into the aorta. They drew a really thick muscle here to show that the left ventricle is having to work harder. It could lead to left heart failure, absolutely. So having that narrowing in the aorta, it kind of helps for a relief vessel. So the ductus arteriosus kind of relieves all that extra pressure in the aorta. But then again, it's going to push blood into pulmonary circulation. Let me go back.
Is there like a stent or something like that in there to help open the aorta more?
So it says this, the coarctation of the aorta is ductal dependent. Do you know what that means? Very good. It depends on the ductus arteriosus to stay open. Did we talk about cyanotic versus acyanotic? No. All right, so if you have blood coming into the left ventricle, it gets into the aorta, but it's having a hard time getting to the descending aorta. And because of that, it's easier to travel through the ductus arteriosus into the pulmonary circulation. So from me describing that, does that sound like you've got oxygenated blood coming back into the pulmonary artery?
Yes.
Yes,
There's
acyanotic.
And the arteriosus running open, is that just to reduce like the back if it's been or make it even narrow?
Yes. Yeah, very good. So I think of it as a pop-off valve. If it can't get through the aorta, it's going to go into the ductus. Right, we'll talk about aortic valve stenosis, which is pretty much the same thing. With the aortic valve not developing properly, the normal amount of blood doesn't get through the aortic valve. So here it says narrowing between the left ventricle and the aorta. You're going to have reduced blood flow to systemic circulation. It leads to left heart failure pretty quickly after birth. So with aortic valve stenosis, it may help to have a patent ductus arteriosus. And how do we keep the ductus arteriosus open? And it tells you to deliver prostaglandins. All right, now, do we have a cyanotic or an acyanotic defect? Let's take a look at the picture. So the oxygenated blood is having a hard time getting into the aorta. This valve is so narrow, it's just letting a little stream of blood get into the aorta. Most of the blood is back here in the left ventricle, the left atrium, in the pulmonary circulation. Now we have so much blood in the pulmonary vessels that it causes high pressures in the pulmonary vessels. And it doesn't show the ductus arteriosus on this. That's interesting. I guess we have to use our drawing tool. Does this fill it in? I'm not going to play. So just use your imagination. You have a ductus arteriosus. Blood is not getting through the aortic valve. How does it help to have a ductus arteriosus? See if you can figure it out. Left to right, that would mean the blood in the aorta coming into the pulmonary artery?
Right to left.
Yes, very good.
I get very.
Oh, that's okay. So with this one, there's a lot of thought that has to go behind that, right? Because you've got blood not getting into the aorta. Okay, if it doesn't get into the aorta, what happens? All right, it's going to back up. It's going to back up into pulmonary circulation. Now that you've got a lot of blood in the pulmonary circulation and that blood meets the ductus arteriosus, what's going to happen? It's going to want to flow through the ductus into the aorta, right? Because at this point, you have low pressure in the aorta, high pressure in the pulmonary artery. Cyanotic defect. So this backup causes high pressures in the pulmonary vessels, and there's low pressure in the aorta because the blood couldn't get there. Obviously, blood is getting there, otherwise the baby would be dead. So I exaggerate it just to help you understand it. But there's low pressure in the aorta, high pressure in the pulmonary vessels, and that's going to cause the blood to flow through the ductus into the aorta. So you're going to have deoxygenated blood flowing into the aorta. So right to left shunt. Did we talk about everything here? Oh, we just had to answer the cyanotic versus acyanotic. So you're good with that? All right, and this is where we take a break. So I'll pause the recording. All right, so we'll continue on talking about tetralogy of Fallot. Just want to make sure that you understand that congenital heart defects are not on the exam for next Monday. Next Monday's exam is on oxygenating the neonate and on mechanical airway and mechanical ventilation of the neonate. All right, now for tetralogy of Fallot. So tetra is 4, and there's 4 heart problems with this defect. First thing that happens is the baby is born with the heart having a hole between the ventricles, so a VSD. They're born with the pulmonary artery not developed. So hypoplastic means smaller than normal. So the pulmonary artery doesn't develop normally. The third one, enlargement of the bottom right side of that. This is written kind of for lay people, so that's why I have to read it and turn it into terms that you guys understand. So right ventricle becomes enlarged because it's trying to push blood into the pulmonary artery, and the blood isn't getting into the pulmonary artery very well. So that causes the right ventricle to have to work really hard, and then you get that increased thickness of the heart muscle around the right ventricle. Question?
Hypertrophy of the muscle.
Yes, hypertrophy of the right ventricle. Very good. It says the aorta is lined up over the hole between the 2 ventricles. So normally we want the left ventricle to pump blood into the aorta. But with that hole between the 2 ventricles, both ventricles are pumping blood into the aorta. Weird, right?
Yeah.
So you've got your deoxygenated blood getting into the aorta, you've got oxygenated blood getting into the aorta. Pretty crazy. Okay, here's a picture of what we were talking about. So the baby is born with a VSD, or ventricular septal defect. The pulmonary artery is underdeveloped or hypoplastic pulmonary artery. So you can see how when the right ventricle contracts and is trying to push blood in there, it's meeting a lot of resistance. So that's going to cause that right ventricle muscle to hypertrophy. And then because there's an opening and between the ventricles, the aorta is accepting blood from the right ventricle and the left ventricle. So what do you think about oxygenation in this baby? Yes, very good. It's going to be a cyanotic heart defect because you have deoxygenated blood getting into the aorta.
Can this be repaired with surgery, or is this always gonna be like a chronic issue?
It can be repaired with surgery, but there's, I think, several surgeries that have to be done rather than just one.
Is tetra?
4.
Oh, everybody knows.
So here, the ductus arteriosus is handy because blood in the aorta can go through the ductus arteriosus to get to pulmonary circulation. Does that make sense? If you can't get blood to the lungs here, how about getting blood to the lungs here? And now it doesn't show the ductus again. So can't get blood to go to the lungs. Now we can get blood from the aorta to flow to the lungs.
Those are the golden blades.
What?
The golden glades of medicine. I like that.
So in this case, it's kind of like you're getting chunky both left and right. Because like at the bottom, it's both going up the aorta, but at the top, it's left to right, isn't it?
Ah, good point. So it still causes cyanosis.
Yeah, because it's mixed blends.
Getting into the aorta.
But at
Yeah.
the same time, it's kind of like chunky from both ways.
Yeah, it's kind of like mind blowing to figure all of this out. So you're right, the blood that gets into the aorta, you've got oxygenated and deoxygenated mixing here. Then that oxygenated, deoxygenated blood comes into the pulmonary circulation, gets oxygenated, and then comes back to the left side of the heart. Yeah, pretty crazy.
Yeah, my head hurts.
Yeah.
Kids that have this have a lot of other problems too, though. Usually,
It's not just limited to tetralogy of flow.
yeah, they've got other developmental sort of genital problems. You know, because a lot of the kids that I pull out of, I used to pull out of kids pulmonary and where our comprehensive changes. They have this.
Wow.
So this causes other developmental problems.
Oh, I see. It's not just limited to the pulmonary artery.
Which makes sense, because if your heart's not operating properly,
You're not getting good blood flow.
then everything isn't gonna operate either, so.
Yeah. It says that the chest X-ray shows the heart looking like it's shaped like a boot. Can you figure out why?
Because the right ventricle is bigger than the left.
Yes, very good. It's the hypertrophy of the right ventricle, kind of looks like the heel of the boot. The severity varies from one child to the other, so it depends on how narrow the pulmonary artery is and the pulmonic valve. It says that cyanosis will increase intermittently. Any increasing venous return to the heart results in a larger right to left shunt. So when there's a lot of blood coming into the right ventricle, more blood will go into the aorta from the right ventricle. Make sense so far? A lot of blood in the right ventricle, a lot more of the blood going into the aorta will be from the right ventricle.
Yvonne, is this a defect that's only found on like full term too, or is this gonna be previous too?
The heart develops, I think, during week 8, so it would affect preemies and full term.
Because I just see the O2, because I was thinking before I saw the slide, like, can't you just give them like, you're gonna have to give them higher oxygen to make sure they're getting oxygenated, okay, but I know 100% is definitely been going on for a long time.
Oh, for the preemies, yeah, that's true. Yeah, good point. The more blood that flows back to the infant's heart, the worse the infant gets. So you're going to have increased blood flow back to the heart when the infant is crying. You know how when you take in a deep breath, that big negative pressure pulls blood back to the heart from the superior vena cava, inferior vena cava. So when you have an increased blood flow to the right heart, you're going to have more shunted blood. Same thing with feeding and the sucking, during feeding increases blood flow back to the heart. Defecation, I don't know how, because that's bearing down. I don't know how bearing down creates more blood flow back to the right heart. So anyway, when they're crying, they turn blue. It's given a name. It's called TET spells. So TET spells are increased cyanosis or increased shunting into the aorta. So treating a TET spell, it says decreased venous return back to the heart by pulling knees up to the chest. So the thought is if you pull the knees up to the chest, you're not going to have the blood draining from the legs and getting back up into the thorax. So that helps. Administer 100% oxygen. That's going to help. And then giving morphine dilates. It's a vasodilator. So that's going to prevent blood from flowing back to the heart.
What's the mortality for?
For tetralogy of Fallot? I don't know.
Pretty high, right?
Can you do a Google search? Like mortality rate for tetralogy of Fallot? It's tetra.
Just another question. If the baby's like laying down and you sit them up, can they do this too? Because there was one baby I saw and I think it was it was Nikki. I don't know. I saw it somewhere in Jody. And like whenever he sat up in the morning, he turned blue and they said like pat him to it and he like perked right up and turned red again.
I don't know.
So, you know,
I guess we could figure it out once we know the diagnosis and why that happens, and we can rationalize why it happens, but I can't diagnose just based on that.
I just figured because gravity, you know.
Okay, so it's more like causing hypotension and deoxygenation somehow.
Maybe.
What did you find, Chris?
The 80% to 90%, I guess, is not.
Wow, okay. So after surgery, they do a lot better, I guess.
That's after full repair.
Oh. I wonder how many of them make it to total repair.
Right.
Okay, so that was it for tetralogy of Fallot. The next one is AV canal. This is a defect that's really common with trisomy 21. Do you know what trisomy 21 is, or do I have that on the next slide? No, I don't see it anywhere.
I've got an interesting stat. They say that, although you have the survival rates with complete repair, you don't live that long. The survival rate is like 30 to 50 years after total repair.
Oh, really?
I expectancy is not as long.
Oh, so it's not like go to surgery and now you're fine and you live a normal life.
No, I don't think any of the people know.
Wow.
Because I think, I think they have lots of brain injury and stuff like that too. With some of these oxygenation issues. So they have brain damage.
Wow.
Because they don't develop correctly. Very.
In utero?
Never getting enough oxygen.
Right.
Never developed correctly when you're born and then you kind of trying to fix them, but they never got done. They're already damaged in most of them.
Wow.
Can't fix the brain damage. But they never got enough oxygen.
Wow, I see. So trisomy 21, that's a chromosome abnormality. And it causes more than just heart defects. So there's mental retardation, there's physical,
That's Down syndrome. Right?
Down syndrome, thank you, yes. Yeah, funny story, when I started working at Joe DiMaggio Pediatric ICU. And there's all these babies with trisomy 21, and I had no idea there was a connection between trisomy 21 and Down syndrome for a while. So now I can share that with you guys, so you know it's one and the same. All right, so with this defect, there's incomplete development of the septa between both the atria and the ventricles. There is a common AV valve that takes origin from both atria. So there is a valve between the atria and the ventricles, and that's it. So the second bullet tries to describe this. It says there's a large ASD, a large VSD. So you don't really have a right side of the heart and a left side of the heart. You just got one big frog heart. I think frogs are like that, right? Don't they just have one huge chamber? Nobody knows about the heart chambers of a frog.
He wants us to dissect it.
And then the mitral and tricuspid valves are incomplete. So this results in a large hole that allows the blood to mix among any of the heart chambers. The defect has a scooped out appearance, and that's where the term canal comes from. Okay, we need a picture. So on the left, it shows the heart where you've got openings between both ventricles. You've got openings between both atria. You've got incomplete valves in between them. And then looking at the picture over here, having like a hole, it looks like a big hole in the center, and they call that a canal. So you have the heart contracting, and it's going to cause all the pressures to be the same. Do you notice pressure in the right atrium? 50/5. Pressure in the right ventricle, pulmonary artery, 50/5. Left side of the heart, 50/5. Whether it's left atrium, left ventricle. So
Do the atria and the ventricles, how do they fire? Like, isn't the entire conduction system messed up because of it? The atria fire, and then the ventricles fire, and then this blood gets pumped.
you're right. Where is like the AV node and the bundle branches? So the heart does contract, but where is it?
Does it kick one back into the superior vena cava? Does it kick to the aorta? Does it go to all the?
So does it kick it into the superior vena cava? Here it's saying no. Do you see the pressure? Compare that to the pressure in the right atrium. But if your next question is, how is that possible? Don't ask me, because I don't have an answer for that.
The vena cava going to the atrium, there's no valve there.
Right.
Why wouldn't it?
I don't know. Good point.
Raising systemic blood pressure.
Or venous pressure. So there's definitely mixing of blood in this heart. You're not going to have your oxygenated blood going one way and your deoxygenated blood going another way. So it's all going to be mixed. So here it says, it starts off as a large left to right shunt. a lot more blood goes into the pulmonary artery. So based on what you know about pulmonary circulation, can you understand why that would happen? If you've got the aorta available, you've got the pulmonary artery available, why would the blood want to go into the pulmonary artery?
Yeah.
Excellent, yeah. There's a lot less resistance in the pulmonary vessels. What's like pulmonary vascular resistance compared to systemic vascular resistance? Remember, we calculated that a long time ago. It was like 900 to 1400 for systemic and 100 to 200 for pulmonary vascular resistance. So very low resistance circuit, very laid back, very open vessels.
I get, when I saw the autopsy, somebody during paramedic school, I got to hold the aorta and it feels like a garden. It's
Wow.
stacked up
Oh, wow.
Wow.
compared to like the sympathetic capo, which is, you can like kind of work your fingers into.
Oh, interesting.
The aorta is hard. So when they talk about like you know, aortic aneurysm or something like that, with the pressure to break that.
Yeah, I was just thinking.
It's just, that's how much pressure is going through. The aorta, it's really strong.
But the breakage of the aorta can come from a weakening in the vessel and it bulges from the vessel. So it says to keep pulmonary blood flow lessened by keeping the infant hypoxic. Does that make sense to you? If you've got too much blood, very good. So if you have hypoxia, the feedback mechanism in the body is to constrict the pulmonary vessels. So keep them hypoxic, constrict the pulmonary vessels, and that's going to reduce the amount of blood going into the pulmonary vessels. So it says supplemental oxygen may be given, but used judiciously to minimize pulmonary vascular dilation. So I was telling you how I worked at Joe DiMaggio. This is what, a long time ago, before I became program manager. So I'm working in there, not my comfort zone, because I just spent like 15 years working with adults, but I wanted to have some experience with pediatrics. So you get your assignment and you're getting busy doing your assignment. Well, a nurse comes in and she says, we just got an admission in this bed. Can you come and set a 2-liter nasal cannula up on her? So I went in, I set up a 2-liter nasal cannula, went back to try to get my first rounds done. And then the intensivist comes to me, come here, I need to talk to you. Do you know what you just did? No, I don't. You just put 2 liters of oxygen on that baby. Do you know what happened when you put the 2 liters on? No, I don't. So what happened was O2 sats went up. It dilated the pulmonary vessels. I guess put her into pulmonary edema. So I learned my lesson the hard way. I share it with you guys so that doesn't happen to you. You can't just take a verbal order from a nurse that says, go put 2 liters of oxygen on this baby.
So did the doctor say it is the question that we have to ask? Did it come from the MD? Not her.
Yeah.
Okay.
Yeah, and also knowing that with AV canal, you don't want to have good O2 sats. So I guess that's the takeaway point. So keep sats less than 90%. Oh, I didn't realize the bottom bullet said what I put up in the top. Oh, wow.
Pediatric is complicated.
Yes.
Yeah.
Since when does putting a 2-liter nasal cannula on somebody get you yelled at? Okay, so that's it for AV canal. I think there was one more thing I wanted to mention about it. So we talk about how it starts off with engorged pulmonary vessels, but it doesn't take long for the pulmonary vasculature to, like I call it like vascular remodeling, and it does become stiffer. And now it is harder for blood to flow to the pulmonary vessels. And then you end up with the babies always being hypoxic anyway. But it starts off, so on your, when you do take a test on congenital heart defects, and it asks you, is AV canal right to left or left to right? If you could start off or answer it by saying it starts off as a left to right shunt. And then once the baby is like, by the time the baby is a couple months old, it becomes a right to left shunt because the blood just can't get into the pulmonary vessels anymore. But for test purposes, let's start off with it being left to right shunt.
Is it like things how like stenosis in the or muscle structure in the heart?
Yes, yeah. Pulmonary artery stenosis, hypertrophy, I don't know, stenosis.
Constriction.
If it's like permanent. like-
Yeah, but it's a permanent remodel of the vessel. So, yeah, it's a hard. I'm struggling with the right word. So sometimes babies can be born without a left ventricle. Can you imagine that? Hypoplastic left heart syndrome. This anomaly has the highest mortality rate. It makes sense if you don't have a left ventricle. So not only is there an underdeveloped left ventricle, there's problems with the mitral valve. We mentioned the left ventricle is hypoplastic. The aorta is narrow. Here it's calling it aortic atresia and coarctation of the aorta. Underdeveloped. All right, so with hypoplastic left heart syndrome, it says to maintain fetal circulation, and you do this by keeping the patient hypoxemic. Again, it has to do with constricting the pulmonary vessels. Keep low oxygen to constrict the pulmonary vessels. And it helps to have a patent ductus arteriosus to get blood to the aorta. It also helps to have an ASD, and sometimes they'll go in and they'll create a hole between the septa of the atria, just to relieve the high pressure in the left atrium. So keep FiO2 close to 21%. Shoot for pulse ox sats of 80 to 85%. Also, you might have an order for giving carbon dioxide because that's another thing that causes constriction of the pulmonary vessels. Remember, hypoxia constricts pulmonary vessels, and the high CO2 and acidosis also constricts pulmonary vessels. So let's keep the pulmonary vessels constricted, and now we want to know why. So by keeping pulmonary vessels constricted, it's going to force blood into the aorta. Why? Why do we want blood to go from the pulmonary artery into the aorta?
To get the oxygen to the body. We need blood to the body.
Okay, All right, so your thought is if blood gets through the ductus and into the aorta, at least now we've got some blood flow to the aorta for the rest of the body to be perfused. You don't even let me finish talking, do you? Go ahead, Rachel, it's your turn. So your thoughts are, wait a minute, if the left ventricle isn't pumping, then how about if we get blood through the ductus arteriosus and at least get blood into the aorta that way? Yes. And that way you're going to perfuse the rest of the body with some blood flow. Okay, very good. What could be another reason why it's better for blood to flow through the ductus? Do we want a lot of blood coming back to the left side of the heart? No, it can't handle a lot of blood flow. There's not much there for chambers. So how can we avoid blood going to the left side of the heart? Let it go through the ductus and into the aorta. Does that make sense? Look at the size of this right ventricle. That's not normal, is that what you said? All right, so the thought with hypoplastic left heart, because you don't have a left ventricle, you don't have much of a aortic valve or ascending aorta, it's better for blood to go into the pulmonary artery, cross over the ductus arteriosus, and get to the aorta. Try to avoid the left side of the heart. Yeah, so this requires a lot of surgeries. And again, it said that it has a very high mortality rate. So from looking at this picture, why do you think it's good to keep their O2 stats 80%? Or am I beating a dead horse too many times? No, nobody's shouting out the answer, so I'm glad I asked. Why is it good to keep the baby hypoxic?
Construction.
Yes. Why do we want pulmonary constriction?
Into the, instead of coming back to the left side.
Very good. We want to avoid blood flow back to the left side of the heart. And if we constrict the pulmonary vessels, there will be less blood flow into the lungs, less blood coming back to the left side of the heart. And how would we keep the pulmonary vessels constricted? I'm just trying to think of different ways of asking the same thing. Keeping them hypoxic and using CO2. Okay, very good. Is this a right to left shunt or left to right?
Right to left.
Right to left. Okay, very good. You're ready for your test.
No, we're not.
You need to review it a little bit first.
Of course. A little. I think we're just.
I think so too.
Which one's the worst one?
This one.
This lecture?
The dean says it's for either.
Yeah, I think so too.
In the past, how have they not been done on this test?
Not too bad. That wasn't everybody's high score. But yeah, not too bad.
Well, it makes sense to me, but it's basically just like, other circulation. Mismatches and stuff.
Chris, this is your area of expertise. Of course, it makes sense to you. It does not to me. It's okay. We gotta make sure we sleep before this test.
Yes.
Because we're gonna
Sleep,
get
good
confused.
breakfast.
Yeah.
Because your head's gotta be in place, so if not, you're gonna be confused a lot.
Mhm. Or make up flashcards or Quizlet cards and just keep looking at it over and over again. I think that's one of the big problems is that instead of it just being 2 or 3, that would be fine. You understand it and you're good to go. But when there's, I think, 10 of them, and this one does that, and that one does this, and how are you supposed to know all of that? Yeah,
It's the tetra, because there's 4.
so that one will stand out for you.
That's probably the only one that stepped out right now.
Well, what about like ASD? That should stand out, right? A hole between the atria?
Well, a lot of the name kind of tells you what it is. Atrial septal defects is a duct between the atria, and think about the pressures, in each atria, which one's going to have more, that tells you which way the flow is going to go. Because everything's going to flow from a high pressure to a lower pressure. So as long as you understand, pressure gradients.
Yeah. Yeah, so for me and my understanding, like looking at aortic valve narrowing and how everything has to back up, that one takes a challenge for me to understand. Oh, okay, good. Which one is the hardest one?
I think this last one, the hypoplastic
For you, that one was the hardest to understand? The PDA. Yeah, I agree. Okay, this is crazy. There's transposition of the great arteries. So instead of the aorta being connected to the left ventricle, it's connected to the right ventricle. Instead of the pulmonary artery being connected to the right, it's connected to the left ventricle. So they're switched. Do you know what that does?
Is that baby okay? Do they live?
You get 2 completely different circulations and they never meet. This is it. Yeah, transposition. So let's do the one on the right side first. Blood leaves the right ventricle and it goes into the aorta, goes to the body, comes back into the right atrium, goes to the right ventricle, goes to the body. You see how it's a complete circle? It never, never, never gets in touch with the lungs.
It's never good size.
Right. Now let's look on the left side. Blood leaves the left ventricle, goes to the pulmonary circulation, picks up oxygen, comes back to the left atrium, goes to the left ventricle, nice and oxygenated, goes back into the pulmonary artery, goes to the lungs, and another complete circle.
So it'll be on mechanical then, like.
ECMO, maybe.
ECMO.
Yeah, they need surgery like
ASAP.
as soon as they're born. They need to have an ASD, like they have to pull the foraminal valve to get some mixing of the blood.
Wouldn't like an ASD or ventricle ductus benefit these patients?
Oh, and then the ductus arteriosus, yes. So in order to get mixing of blood, the ductus arteriosus helps also. So that's the 2 places where blood can mix like right away after birth. And then of course they need surgery to switch the vessels.
Are they able to determine this before birth? That this is happening?
Yeah,
So right away, you know that it's never going to be normal. Never oxygenating the way they should. The brain's not getting enough oxygen. The kids are never going to come out normal. So,
But in fetal, we don't really use that, right?
After the surgery, the kitchen would.
No, I know, that's why they do that.
First couple of breaths are just gonna be. No.
Yeah, I don't know if you can come to that conclusion, Chris. I'm sure some, but I don't think it's all.
That sounds like an easy surgery to fix it.
Yeah. Yeah, if heart surgeons that do this every day, they've got to be pretty good with it. Yeah, because that's just two vessels.
Right, that's why the specialty exists for situations like this.
Yeah. That's why they make so much money. So I don't even know how to classify this because
There's no shunt.
yeah, you have to create a shunt. Yeah, I don't know what to say. I guess it's a cyanotic heart defect because you'll have some mixing of oxygenated and deoxygenated blood here. Some mixing here. I don't know. I'm not going to ask you guys that one.
Thank you.
If the teacher can't figure it out. Sometimes the blood flowing back from the lungs to the left heart doesn't flow back to the left heart. It flows somewhere to some other vessel. Here it says the blood returning from the lungs to the left heart is misdirected. Sometimes it goes into the right atrium, superior vena cava, inferior vena cava. Yeah, I know. What happens during development to make that happen?
Are like different blood vessels, and assuming they shouldn't be.
Just those, just the pulmonary veins.
And it's possible to have extra veins in the thing.
That's possible. So let's find, here's the left atrium. And there's nothing connected to it. Where's the pulmonary veins? So these were supposed to connect. This one was supposed to connect to the left atrium and they didn't connect. And then they ended up connecting up here somewhere. So maybe this flipped. I'm making it up because I really don't know. Yeah. Yeah. And now the blood gets, the oxygenated blood goes to the right atrium.
And then do we get the radium and all that's how it gets back to the rest of the body?
Yes. So you have the blood coming back into the right atrium. How does it get to the left ventricle? Just this, yeah. Yeah. So blood has to go from the right atrium through the foramen ovale into the left atrium, then into the left ventricle, and then to the aorta. It's a long way around. That's pretty funny. You're just gonna pull over to the side of the road and have a picnic?
You're supposed to go right. Now left side of the heart waiting for its blood.
Yeah, you're right. So with Total anomalous venous return. How does the blood get to the left side of the heart? Through the foraminal valve, right? Then you get this big fat aorta called truncus arteriosus. You don't have a pulmonary artery and an aorta, you've got one. Truncus arteriosus. So the trunk is both the pulmonary artery and the aorta. So let's see, the blood from the ventricles both go into this one trunk.
Right, that is the one that needs to go to the lungs. The rest of the body.
You're right. It's not going to know. So you're going to get deoxygenated blood in the aorta. Obviously. You're going to get oxygenated blood going to the lungs. It's going to be a real mess.
Mixed blood all around.
Mixed blood everywhere, yes. Is this the best slide of the whole lecture?
Blank.